Pleasure of introducing our invited guest today, who's Dr. Ann Ye, in these rounds today that are jointly led by the Leong Center for Healthy Children and Child Health Evaluative Sciences. For those who don't know, Dr. Ye is a professor of neurology, the Gary Hurwitz Chair in Neurology. She directs the MS and Neuroinflammatory Disorders program, as well as their fellowship programs here at SickKids, and as a senior scientist in the Research Institute. And over the last number of years, in collaboration with Leong Center and others, she has led a really important program of research. And will talk to us a little bit today about a really good example of how social determinants of health influence a condition for which she has deep expertise on, multiple sclerosis. So, with that in mind, I'll pass over to Dr. Ye, and we'll have some time at the end for questions.
Thanks, Al, and thank you everyone for showing up. When I saw the snow report for Sunday, I thought, is this actually even going to happen? So I congratulate the Leong Center for pivoting very rapidly, and for you all for showing up. So I guess you took time from shoveling your front yards to join. And I also see that I have some colleagues from BC here. So hello to you all, and thank you for joining. What I'm going to talk to you about today, as Al pointed out, I've spent a lot of time thinking about MS, and I've had the opportunity to work together with the Leong Center and others who are really have deep expertise and knowledge about social determinants to really think about how these things affect pediatric onset MS. And so let me just see if I can get this to work. These are my disclosures. And so what I really want to do is to take you partly through the journey that I've taken over the last decade or two, thinking about problems around pediatric onset MS and about the things that can change the trajectory of outcome in pediatric onset MS, focusing specifically on the issue of physical activity. Talk a little bit about an interventional program we're doing, but really to end this talk with the issue of how social determinants of health might change those outcomes, including trial participation, physical activity behavior, and other factors. So let's get started. And I know that this is CHES and not neurology, but I am going to bring you an MRI scan of the brain because this is a typical MRI of what we might see in a child that comes in a typical age. 14-year-old child comes in with can you guys hear me okay? Are you good? Yep.
Perfect.
Yeah, okay, very good. A 14-year-old child comes in with an inability to walk. And, it might be, and this happens very frequently, the child has been in and out of the emergency room, has maybe patchy sensory loss, and that has evolved over the course of a few days to really being non-ambulatory. And in fact, the parent may be coming and pushing the child in a wheelchair. So the ER physician evaluates the child, identifies abnormalities, weakness in the lower extremities, maybe urinary retention and sensory difficulties, and orders an MRI scan of the brain and the spine. Now, if we were live, like we were planning to be, I might point someone out in the audience and say, hey, what do you think about this scan? But I'm just going to tell you this is abnormal. And what's abnormal about it, I have identified here, is that there is a very high lesion load in the brain and the spinal cord. And in particular, there are so many lesions in the spinal cord that the lesions, the white lesions, for those that are not neurologists, appear to be almost contiguous. So very high lesion load. So as neurologists, we might march in the room, and those of you who are pediatricians or have some pediatric adjacent work might recognize the neurologist marching in the room and saying, hey, I know what the diagnosis is, and making the diagnosis. Because with this MRI scan, our neurology side of things has gotten to the point where we can do one MRI scan, and in kids where we can identify lesions like this, we can say at the outset, this is MS. Now, the problem is that disconnect between our diagnostics and the issue that many families, that we all face as clinicians, as caregivers, as people who care about kids, is the question of what this means for the future. And most importantly, whether there's something that can be done to change that course. This is a very old cartoon, but it is an important cartoon, and it identifies what we all have been talking about for many, many years within the MS community. The fact that through time, there is progressive change, and that MS goes through a relapsing phase that eventually becomes inactive, but that progressive disability, motor disability, accrues through time. So, there's a lot of debate within the MS community, or there has been, about when that progression occurs. But what we know now is that from the onset, progression occurs, and that MS is a progressive disease. This was mind-blowing many years ago. It is no longer. It is the accepted thinking about MS. What question we have as clinicians and as families is there something that can be done other than medicine to change the trajectory? So I'm going to talk to you a little bit about not only about disease trajectory, but about some of the work we've done in physical activity. And I promise you, this will come back to social determinants. Because from very early on, something that we noticed clinically, and has been noted by many people, is that physical activity, or high, moderate to vigorous physical activity, can make a difference. There are many proposed mechanisms within the MS literature that identifies through animal models and through human trials that there are marked effects of exercise on outcomes. Exercise, moderate to vigorous physical activity, can encourage remyelination through proliferation of cells that are responsible for myelin. It can reduce neuroinflammation. It can reduce inflammatory signatures. It can increase growth factors and specific brain factors, like something called BDNF, that have been associated with neuronal growth and recovery. And it has effects on oxidative stress. And in human trials, there are studies that have identified associations between outcomes, brain outcomes, and inflammatory activity with exercise. So does it matter in MS in the pediatric population? We spent a lot of years thinking about this, and this is work actually from Stephanie Grover many years ago, who was a research coordinator within our team. And what she did was she had a look at physical activity levels and brain volumes, and in fact identified that that brain and lesion volumes associate with any moderate to vigorous physical activity in kids with MS, meaning the more, this was when she did this, when we first started doing this, we first went to identify how much vigorous physical activity kids were getting, and it turned out that they were getting almost no vigorous physical activity. But what she did was she dichotomized things and said, if you get any activity at all, is there a difference in your brain and lesion volumes? This was cross-sectional work, so it really did not identify any causality, but it showed an association between brain volumes, lower brain volumes, and lower physical activity, or if you got any vigorous physical activity with lower lesion volumes and higher brain volume. So exercise, suggesting that exercise might have a positive effect on outcomes in pediatric onset MS. And I'll just remind you guys that for those of you that don't specialize in MS, kids with MS actually are have very little disability and very little motor disability. And so the concept that kids that had higher lesion load might be less active because they have poor motor capabilities is probably not not the issue here. We think that there actually is an association. We've done other work too, looking at volumes of hippocampal volumes, basically. And this is work from Julia Longoni, who was here with us for a number of years and now is no longer at SickKids. But the interesting thing in this that I want to show you is that she looked at dentate gyrus volume because this is what has been associated with physical activity in kids with in adults with MS, that that in fact dentate gyrus volumes are larger in people with greater physical activity. What she found was an association in kids with without MS, but no association in kids with MS. And the reason for this is probably that kids with MS at that point were getting such little physical activity that all of their activity clustered at the low end, and we couldn't identify a relationship. This is what we think. Okay, what about other signs that physical activity might associate with outcomes? And this is work from a wonderful medical student who's now a family medicine resident. She might have finished her family medicine residency by now, but who looked at cross-sectionally at structural visual metrics using outcomes from a machine called the optical coherence tomography, which in MS is known to demonstrate structural abnormalities that correlate with brain volumes. And what she found was a very similar association, that the structural visual metrics that we were looking at, the retinal nerve fiber layer thickness and the ganglion cell interplexiform layer, associated with moderate to vigorous physical activity. If you had moderate to vigorous physical activity, then you were more likely to have preserved retinal nerve fiber layer thickness. Similarly, in a longitudinal, for those of you that are wondering, I've just been showing you cross-sectional work and longitudinal work. Another medical student, and this is all work that actually Sam Stevens, who I think is on the call and is partly part of CHES as well, worked closely with our students on. And so Sam's picture should be up here too. But this is from another medical student that was with us, and where we asked the question if this mattered longitudinally, because the work that we had done to date was just cross-sectional. And in fact, what Nahid demonstrated was that any moderate to vigorous physical activity associates with better OCT metrics, suggesting that there may be a causal relationship. Okay, so I've shown you, and this is really to let you know that what we've found is physical activity makes a difference for outcomes in pediatric onset MS. And in fact, the same association was shown in brain metrics with a wonderful a medical student from Germany who came with and joined us, Ines. And again, Sam had an instrumental role in this work, where she demonstrated that dentate gyrus and lesion volume associated with fitness in MS. So we have fitness, we have moderate to vigorous physical activity associating with both brain metrics and eye metrics. This is just other work she did, which talked about brain and thalamic volume, showing a similar association. Okay, so what about physical activity, and what kinds of things might be of relevance in pediatric onset MS? And in fact, does anything out, are there things in the environment that might make a difference? We're still not at the social determinants of health, but I just want to show you a little bit of this. So this is work that Sam and another medical student have worked on for a long time, and this is in collaboration with a very a wonderful colleague, Helen Tremlett, who I think may even be on this call. I think I saw her come on, where children from across Canada with MS were donated stool samples, and their stool samples were evaluated for the microbiome components and diversity. And so there are a lot of people that know a lot more about microbiome than I do on this call, but we did, and Sam especially, dug very deeply into these data, reminding everyone that diversity seems to matter for outcomes. I'm not going to talk much about this, except that that diversity, and I'm only going to talk about diversity, not the specific microorganisms, but this is just to remind everyone that there are a couple of kinds of diversity that are spoken about within the microbiome literature. One is the variety in one group, how much variety is there within an MS group, and which is the alpha diversity, and beta diversity which is how variety in different fruit bowls differ, meaning with different cohorts. And what Sam showed basically was that those who have greater strenuous activity have lower alpha diversity. And that, in fact, there is a dose effect such that each hour of week activity associates with a 1% decrease in alpha diversity. And this may suggest a benefit of physical activity that associates with differences in the microbiome. She also demonstrated that beta diversity, those kids with higher physical activity have increased beta diversity, which was not seen in the other comparator groups. Okay, so I hope I have convinced you, number one, that MS is a progressive disease, and two, that we can potentially make a difference with physical activity, or physical activity may associate with differences in structural outcomes related to MS and in disease activity. This is other older work from Sam, where I just want to highlight that kids with MS, where she demonstrated that the progression in MS relates not only to structural metrics such as the eye and such as the brain, but to depression and fatigue, which we have had a particular interest in over the last decade and a half or two. And what she demonstrated here in this paper from a number of years ago, but I think it's really important to us, is that not only are fatigue and depression progressive in MS, the older you get within our population, the more the higher or worse your depression and fatigue scores, but also that kids with physical activity, and these are the MS lines. The blue is those kids with high activity, and the red is those kids with low activity. Those kids with high activity consistently have lower depression scores and lower or better fatigue scores. And in fact, that small amounts of increases in moderate to vigorous physical activity can associate with better depression and or fatigue scores. So going back to the beginning, I talked to you guys about physical activity, about how good it is, or how good we think it is, the benefits we think it has for children with MS. I also talked about the fact that we had so few kids in those structural studies very early on that satisfied moderate to vigorous physical activity recommendations for children, that we didn't even get a signal in some children. We found in that early study that children with MS had almost no moderate to vigorous physical activity. And you all know, as well as I do, that it's incredibly difficult to tell a teenager. Most of these kids are teenagers. And our thinking as people who want to bring change about is, well, if we see something that can have an effect, why don't we just tell them, why don't we just change the behavior? So I don't know how many of you in the audience have teenagers that are really good at listening to you, but I've had teenagers at home, and mostly if I said A, they would do B. And certainly as a physician, writing a prescription that says, go get more physical activity, or even, what we see in clinic very frequently is that parents will say, well, Dr. Ye says to get more physical activity, so you should do it. And the parents will say, I'll leave the room. You just tell them what to do. And that is obviously incredibly effective, right? Not really, right? And so we set about asking how to bring behavior change about. And in following a well-known set of parameters, looking at social cognitive theory, we asked the question of how those changes, which kids had which kids that were doing physical activity, that were doing well, which qualities they might have that could potentially be amenable to change in other kids that might be having trouble with physical activity. And what we found, and this is to be expected within the literature, but it was interesting because what we found was that, as you might expect, physical activity, self-efficacy, and exercise goal setting associated with vigorous physical activity. But what was interesting and unusual for me about it was that even if these are the tenets of the so-called social cognitive theory that associate with better outcomes, the association was present in kids with MS and not in kids who didn't have MS, meaning that those things were particularly, we interpreted it as saying, well, they are particularly important for kids with MS in terms of getting them active. And so this is an app that we developed a few years ago and we've been using, called the Atomic app. We've piloted it and tested it because the next step was really to say, let's not write a prescription, but let's find a way to help kids become more physically active, with the ultimate goal of seeing whether we could change outcomes. What we discovered when we did our pilot, however, and this is a very messy graph, was that that just like I had mentioned earlier, if you just tell kids to do something, they might start out doing something, but it's really the interactions that they have with others that might encourage them to do more. So here, I just want to highlight on this graph that the intervention was a 12-week intervention, which was likely shorter than, well, it was. We decided it was shorter than would be effective, but we had coaching calls every 4 weeks, and you'll see there was call 1 at week 2, call 2 at week 6, and call 3 at week 10, with kids using the app. And these are the steps and step changes. And oops, what you'll see here is that that kids were pretty even in their behavior, and it might even go down right before a call. And then after a call, we found that the physical activity behavior increased, and then it might decrease. And then in anticipation of especially the last call, kids were increasing their behavior, their physical activity behavior. And what it really demonstrated to us was that it wasn't just the exercise goal setting, it wasn't just the self-efficacy, but that social support and that network of really being able to support the new behaviors or changes in behaviors was important. And this is Mina Lee. She was a student with us a few years ago. And what she did was she looked at interviews and facilitators in that pilot study and identified the coaching calls as a key ingredient. And that in fact, the kids were telling us that more important than a lot of other things were the social connections and social support. This is work from Paul, who Ellie mentioned earlier. Paul was a postdoctoral fellow that was with us for a few years, and he went on to ask the question within our data of how social network size associates with physical activity. And in fact, found that larger social network size associates with higher levels of physical activity, giving us some clues as to how to help kids to improve their behavior and thinking about what helps with this with a positive outcome there. We've just completed our intervention, which took account of all of those things. It was a longer intervention. And in fact, and this is Sam has just finished the analysis of the trial. It was very exciting to be able to finish this trial, especially since we started it in COVID. And she demonstrated that the intervention group had 300 steps a day more than controls at 6 months. This was not statistically significant, but that sleep and cognitive fatigue, because we were really interested in changing the dial or moving the dial on kids with depression and fatigue, and that sleep and cognitive fatigue were significantly better in the intervention group and not in the control group. Okay, so that's really thrilling and exciting. That's the journey, and I'm going to take you to social determinants now. You wondered where I was going with this, but social determinants are really important for this because we have found that physical activity makes a difference, should make a difference to kids. And we even have developed an intervention that seems to change physical activity behavior, which could take kids on the road to having better outcomes. So, is that the end of the story? It's not. And you all know that, being people that are interested in these questions, because we know that, and this is a paper that we did last year, really considering the question of how, and this was in an American population, of how inequities shape biological outcomes. And it's really to take us back to that question of progression in MS and how we understand the different factors that can prevent progression. Here, we looked at physical activity and we said, we think physical activity can make a difference. But what we found within our population is that while we may be able to, in a structured setting, find there are associations between physical activity and outcomes, and anything like disease-modifying therapies and outcomes, that access matters. And just one example of this is that of therapy. So we want to move the needle on progression. We want to move the needle through physical activity. But what is very clear, and this is work from Lauren Strasser, who is a fellow with us now and has done marvelous work on disease-modifying therapies and use patterns. And what she found within our own center, which we pride ourselves on being a center that sees no differences between kids, is that there are differences in who has access to highly efficacious therapies. And what she demonstrated was that high efficacy therapies, which we know can move the needle on progression, are almost exclusively covered by non-governmental sources, including private insurance, which has the potential to widen the gap between kids who have access to these things and kids who don't. Now, why does this matter to the original, to any of what we're talking about? And it's to remember that if we, if that if we concentrate on the individual, we will not remember the kinds of things that can actually drive outcomes, like access to therapies and also location, where people live and what people have access to, or what inequities might exist within their environment. And this is work again by Paul and another medical student that was with us, where we asked the question about risk of depression in racialized youth with MS, where we found that racialized children with MS were much more likely to suffer from depression. Bring that back to the MS cohorts, depression, and the associations with physical activity. It takes 15 extra minutes, 15 to 30 extra minutes of physical activity to move the needle on depression. Depression is consistent and worsens through time, and racialized children with MS are likely to suffer from depression, meaning these children are ones that might benefit the most from an intervention like the one we were talking about. Yet what we know is where you live matters. So I gave you all of this exciting news that our trial was finished, that we were able to recruit, and that steps changed with kids. Well, I guess that's the good news. The one thing that has become very very clear to us in running this program is that performing interventions, having kids participate in interventions is really, really hard. And so the numbers that we have showing improvements in fatigue, improved step counts, do not tell the whole story. So we noticed that there were a lot of trial dropouts within that particular trial that we were performing. And in fact, if you look at the different sites, and these numbers are not entirely up to date, but they demonstrate what I'm trying to tell you, is that there were 4 sites. And of those sites, site A, I'll tell you, was SickKids, a Canadian site. Site B was a Canadian site, and site C and D were American sites. And while we don't have I'm not going to share the demographic information for you. What I will say is that the reasons for withdrawal from our trial, the lower number of withdrawals from our trial, might be perceived as because we were the primary site, we had the most kids, but the other sites were highly sophisticated, dedicated sites with very strong central and excellent research teams, and they still had dropouts of about 50%. And the question is, does this reflect real life? Are there demographics and factors that drive trial inclusion, participation, and completion? Because it has huge meaning for the kinds of things that we intend to do in terms of interventions, of getting interventions out to kids. Because I have to tell you that when we started thinking about the atomic intervention, our goal was to get the intervention to kids, and that lived in different places. And all we were thinking was that we wanted to make something. We knew that participation in trials, interventional trials, was very difficult. And we wanted to make something that was flexible, that kids could do on the go, that they wouldn't have to come to a central location for. And we still had high dropouts. I'm going to show you work that Victoria, who is a grad student that has started time with us, has started to perform on our cohorts, because after we saw this, it became very apparent to me that it was important not just to look at what was going on physiologically and learning what the physiologic outcomes of higher levels of physical activity were, but to find ways to actually understand who we were actually studying and whether we could make our information, make our studies more relevant for everybody and not just for the people that could participate in trials. So Victoria has started out, and she's on her early graduate school journey, but she started out looking at 3 RCTs that we've performed through the MS Center. And they're both behavioral and pharmacologic trials. One was an adherence study we did years ago. One is currently a trial that we've just wrapped up, and the other is the atomic trial. And what is the commonality is that there were both US and Canadian sites, and kids of what we think are high socioeconomic variability, but we don't know that. It could very well be that we find that that socioeconomic status is the number one driver of who gets to participate in a trial. She found an imbalance in the number of children with diverse backgrounds and has to look more at that. And when she compiled all of the studies together, she found she continued to find what I showed you as the atomic thing, our first observation, that Canadian sites were much more likely to have trial completion than the US sites. It's really not clear what that means right now. Okay. Now, so location matters. It seems to make a big difference. What about other things in terms of physical activity, access to facilities and things like that? Because again, thinking about the embodied inequities, where we live makes a huge difference to what our outcomes are. And this is work from Sonica, and I saw that she signed on, and it's a paper that was, congratulations, Sonica, was just published in MSJ, in Multiple Sclerosis Journal, in the last few weeks, and this is actually from the proofs. But what Sonica did was ask a question. So we know that we seem to have found that location matters when it comes to trial participation. What about actual physical activity? How can we get kids to be more active if they don't have access to the kinds of things that will help them to become more active? So Sonica asked the question of whether there were things in the built environment that made a difference to outcomes. And I'll just show the most striking finding from her work. And that is that that the closer you are to green space, the more likely you are to have higher physical activity. And the fact if you have more green space at 500 meters, you are 1.6 times more likely to be active. Now, why does this matter? Of course, if you're close to a park, you're going to be active, and that seems obvious. But the issue is that green space and parks are limited to certain areas and divide by socioeconomic opportunity. Our population for this, Sonica's population for this, was relatively small. We need to do further work to understand what other determinants were meaningful or are meaningful for encouraging physical activity. But it's really just to say that not only does it matter what you do, not only does the biology matter, but the biology is driven by factors such as whether or not you can participate in a program of activity or whether or not you have green space around you. Okay, so I'm going to wrap up now and can open up for questions. I know that this was a sort of a meander through the through some of the biology or the structure that we found that associates with outcomes in kids with MS with a very specific focus on physical activity. We can talk about disease modifying therapies and that kind of thing as well, but I really wanted to focus on this physical activity work. And and we think that we have identified physical activity, high levels of moderate to vigorous physical activity that can change the projection, the trajectory of progression, whether it's psychosocial problems, fatigue and depression, or it's structural problems, retinal atrophy, brain atrophy in MS. We also feel that our theory-based approach has merit and deserves further work. But finally, that despite all this work, no therapies work for children without attention to the social determinants of health. And what we really want to orient our future work on is integrating these perspectives, really thinking about how to get interventions, therapies to kids with MS, regardless of where they live, what they have access to, what their neighborhoods look like, and really understanding how we can identify better ways of having kids participate in trials so that our work can be representative of the population we serve. This is I really appreciate, especially appreciate the Leong Center. And I'll have to say that if it were not for the various calls of the Leong Center, we wouldn't have been able to push this work forward, which I consider to be an essential part of our big picture work of improving outcomes in kids with MS. These are just some pictures from our group, and all of this work, as you can see, was I was not the star of any of this work. It was all done by amazing trainees, and I really have to thank them for all of their hard work. And I'll open up for questions now.
Thank you, Anne. That was excellent. I'm wondering if maybe you could stop sharing screen just so we don't look at postage stamps of each other.
Yes.
I'll open up the floor for any questions or comments from anyone. Maybe I can start. So Anne, it's interesting the comments you made about exercise being such an important mediator of outcomes in MS, and also the notion that exercise, particularly for youth, is often a social phenomenon. So wondering if you might want to comment in terms of the target of interventions. Is it at the level of the individual, the level of the community, the level of the school? And how are you thinking about that in terms of the population
Yeah,
that you've been focused on?
Yeah, Elle. So I guess our work primarily, our work originally was focused on the individual. And as you can see, you can't focus on the individual with great success if there are all of these other barriers that we demonstrated. So we have a focus on the individual with our app, and that is to change individual behavior. But our future work, and I'll point to some of the work that Sam has done, is looking at community resources and engaging communities around Toronto in understanding how to improve access and facilities to people with kids kids with many different disorders, including MS. And so we are targeting interventions at multiple levels. Policy is a bigger, I guess, a bigger challenge for us because we are a small population. But for sure, moving beyond the individual is incredibly important. And that's the reason too that we're looking at our trial participation because we identified a real problem. And I mean, I didn't realize we had that problem. I really thought that everything was good and well, but clearly there's a problem with trial participation, trial completion, and that it probably falls along socioeconomic, is cleaved along socioeconomic lines.
Thanks, Anne, and really appreciate that you actually explored the issue of trial attrition. People often talk about trial recruitment and our lack of diversity in trial recruitment, but equally, if not more important, is whether we're able to retain participants within trials. So really, really important information. Thank you. Any other comments or questions for Anne?
People are probably just exhausted by their shoveling from last night, and they're just probably taking a break. Um, there's Brian. Hi, Brian.
Hi, Anne. Great talk. Thank you.
Thanks.
So, Anne, what's the next step in the program of research related to social and structural determinants of health in this population? Just wondering where you're going next with this.
Yeah, we're doing a few things. We've actually there are a couple of things. One is related to access to therapy and access because we're really focused on changing the trajectory in all kids with MS. And so we have a whole group of people within our group that are looking at therapy access. And we're doing some national and international efforts related to therapy access. What I didn't talk to you guys about today is the fact that MS as progressive disease has changed with the use of high efficacy therapies. And in Canada, we are unprivileged to not be able to offer our kids high efficacy therapies at onset. And so some of the work is related to understanding trajectories of disease and access to therapies in different places. And other work specifically related to trials is the work that we've started looking at trial attrition, trial participation, and that's work that I've got a grad student that I mentioned, Victoria, and I see she's on the screen that's working on that. We hope to understand that better because, we've made this app. Samantha Stevens, who I think is on here, has put a tremendous amount of work on the app. We've got a lot of people using the app, not just in MS, but if we can't get it to the kids that need it the most, and we can't figure out why they're not using it, then it's a problem. So that's going to be another big step for us.
Thanks, Anne.
Everyone is stunned into silence.
The problem with virtual meetings is people sometimes bite their tongues a little more in these things, but I think the clarity of your presentation and helps as well. We have a one hand up from Lama.
Hi, Dr. Thank you for the great talk. One question I wanted to ask you is, what do you think is the main challenges that we face to implement clinical trials for this specific group of patients with lifestyle modifications, whether it's dietary or something like what we're trying to attempt, which is like physical activity and having a special plan for certain activity levels?
Well, there are all kinds of barriers to, when you're talking about implementation, are you talking about barriers to running clinical trials or barriers? I think one of the main challenges we have actually is defining outcome metrics clearly so that uh, we choose something that is going to be a clinically meaningful outcome that will change with the kinds of things that we do. I don't know how many people on the call deal with lifestyle types of things, um, but it's actually, compared to giving an antibiotic where you either live or you don't live, an outcome from a physical activity study is actually you're not going to be making as big a biologic or other change. It's much harder to measure. So one of the barriers is actually proving efficacy, and the other is identifying the right population. There was a very large trial that looked at physical activity in adults with MS, with progressive disease, and it was a negative trial. And the thought was that the outcome metric was not chosen properly. So that's the barrier because, we're able to show all kinds of things cross-sectionally, but we are not able to really uh, create trials that have that are able to show a big effect. Very challenging. And I know Ryan's done trials on interventions, physical activity interventions that where the effect size was not that large, and has faced a lot of challenges in that work as well. And I agree, Al. I actually doing virtual gatherings. It's really hard to get people to raise their hands and ask questions.
This is Nora joining from Kingston. I'm unable, I only have access to the call from my phone because my internet is down. I'm just, so I apologize for not raising my hand. I have a question for Anne, or I guess a comment. Can you hear me well?
Yes, Nora, thank you. And thanks for your question.
I just wanted to thank you for your comment about outcomes and the difficulty of some of these kind of psychosocial outcomes observed in trials, because I think my experience in kind of implementing a lot of these outcomes are new to trials. They're not, they have been common in research for years, but we haven't been using them in trials as much. And I think it's great that we share some of our experiences, because what I've observed is the amount of variability in the outcomes is so high. And so we really need large sample sizes, but in pediatrics, we don't have them. And then on top of that, because these outcomes are so important, we need longer periods of observations in order to detect them. So I think that those challenges are particularly unique, and why kind of adult structures of looking at outcomes in the context of trials can be particularly challenging. And so I just wanted to reinforce that that's something I've observed as well, and to other people who do kind of psychosocial work and trials, pediatrics, that it's not just you. It's a challenge for all of us.
Thank you, Nora. And I think that's so important, because I think one thing that happens, and it all has it, some of it relates to the way that we have to design our trials, or randomized controlled trials and things like that, where you need these huge numbers and you're not making a big change, right? And so I think we have to think about different ways of designing trials and finding acceptability and outcomes. So I agree entirely with you, because what this has led to has been a lot of failed trials, which are designed with the underlying assumption that the outcome should be just like a pharmacologic outcome, like an antibiotic.
Yes,
We
yes,
got to think more about
absolutely.
this.
And also, if our community can get behind the idea that we need longer periods of evaluation to pursue the more important outcomes as well, that I think that that would be great.
Yeah, Nora, I agree entirely. We actually stretched our outcome, our measurement from 3 months to 6 months on this on the trial, you know, from the pilot to the other trial, and it's still I don't know if it was long enough still, but yeah, a very important point, Nora. I think we've got Colin next.
Thank you. And just a quick comment and I think a short question. I'm struck by how often exercise, a balanced diet, good sleep, and proper emotional support can have an impact on health. So it's not just on your talk today with MS, but it seems like almost across the board. And you wonder sometimes whether there should be a general recommendation for everybody that comes in through the doors of the hospital. But my question is, I think, an extension of other people's questions, which would be, if you offer up a diagnosis like MS and then offer up lifestyle changes as potential therapy, how do the families respond to that? Or are they expecting sort of medication, surgery, something more quote unquote advanced than lifestyle changes?
Yeah, so Colin, the interesting thing with our population is that the kids get better and they have no disability, right? After they have an event, they have a neurologic event and then they recover and they're teenagers. And so the parents come in with incredible guilt that they've done something wrong, but also wariness about pharmacologic interventions. And so one of the most common questions, and this is true across the MS community, but especially within our community, is what can we do to change the outcome? To the point where for a while, and it's a little less so recently, but especially during COVID, a lot of families were telling us, well, we're going to wait to start therapy and we're just going to try something natural. Um, and so there is actually a huge appetite for doing something that is non-pharmacologic within the MS community. And the other piece of things is that we have pretty effective therapies, but kids remain with residual symptoms that include fatigue and depression. And those are incredibly difficult to treat. And so again, you know, families are looking for something and want fewer drugs, right? They really like, you know, half of our families won't even give vaccinations, you know, and so to tell them that they're starting on a lifetime of immunosuppression is a huge deal for families, especially when there's no disability, no visible disability. But I agree with you. I mean, it is kind of a motherhood thing. We should be doing this for everyone. But I think from our perspective, there are brain-specific changes that are supported by physical activity that could improve outcomes, and anti-inflammatory actions, which would identify it as disease modifying and not just in the realm of it should be good for everyone.
Yeah.
So on that note, after a slow start, lots and lots of questions, and of course we're over time.
Oh, I'm so sorry, Al. That was me, my fault.
No. It's great. I just I'm glad we had a rich discussion, and really appreciate all the insights from your talk, Anne, which I think